But the evidence base, like everything. So these studies, I mean, when I taught, to this day, I try to teach my team, younger people in the team who I think are really sharp and really do care. I mean, we've curated this team of people who are amazing. And a huge part of being amazing in what we do is caring.
Yeah.
And you have to care.
Yeah.
And you also have to be able to think and to think critically and to not just take everything hook, line, and sinker that's given you, right? And so like the evidence-based thing, most of these studies are done short term. They use, by necessity, and again, I think Dr. Patty would probably say something similar. By necessity, they use things like rating scales, right? How are you going to quantify the change? You have to have some sort of a rating scale. Sometimes they make up their own rating scale.
That means you ask someone on a scale of 1 to 10, how do you feel?
Yeah.
Right. And or a scale of 1 to 7. And then, so there's some obvious issues there with subjectivity changing even within one person over time. But
and their own ability to stand back and observe themselves.
But you've got to have some sort of data, right? Some sort of measurement. So that's the best we can do right now.
Right. And the placebo effect,
is real.
And, I mean, there's just so many different things, but say depression study uses the PHQ-9, 9 questions about how you feel, all of which are felt to be in some way germane to mood and progress towards relief from melancholic depression, and so you do some type of an intervention and you periodically administer this, and then creates a beautiful PowerPoint graph with the line going down or not, and the placebo or control group that didn't receive the treatment, did it separate? Some of the limitations of the math that's applied there, like everyone, the mighty p of less than 0.05, which is less than a 5 in 100 chance it happened by
randomness,
random chance alone. It sounds like. That's pretty good. Yeah. But then if you really look at individual predictability, it's like 51-49.
Yeah. So it's like retroactively you can go, well, there's less than a 5% chance this was random. But with that, when you look at that test's ability to predict future results, which is kind of the point of science, is to be able to predict what's going to happen reliably. And that's what I would say, like the diagnostic utility, the utility of like these diagnoses is very low. Or of an intervention is what we're kind of talking about now, the evidence base.
Yeah, the evidence base. So the evidence base, someone comes out with a study that says a dozen sessions of CBT or, some particular type of therapy. CBT is the darling of the evidence-based crowd. So a dozen CBT sessions, produce an effect size of, 0.34 and, patients, reported this much improvement, and clinicians said their global assessment of functioning, the GAF score went up. And so well, that's great. So what we now know is that in a 12-week epoch with these particular patients and in the med trials, all of whom are cherry-picked, right?
Pre-selected.
Pre-selected. Yep. And the pre-selection process in the med trials excludes pretty much everyone that would ever walk into my office.
Right. Anybody who is mentally ill. Yeah, you're right.
Right. Well, and and again, some of this is selection bias. So again, to be balanced in what I want to say, some of this is selection bias because now my role is only to see people. I like to say they've been kicked out of every decent practice, and they have to come find us, right? And they come find us because we do things differently. Because shockingly, we talk to people. We offer therapy of various sorts. We offer neuromodulation, all these different things. Okay, let's talk to people about lifestyle things, right? But in those drug studies, like if a drug is being assessed for its efficacy in depression, then they will exclude people with OCD, people with bipolar disorder, people with various forms of anxiety, people with substance use. Pretty much everybody that comes to see me who has refractory depression has one or more of those things, oftentimes more than one of those things. And so again, applicability, how does that extrapolate from the study to the actual clinic where you meet people who didn't play by those rules?
Yeah.
And again, the drug trials,
it's not about playing by the rules necessarily. Like they're presumably they're adhering to what you're asking to do, but they just don't fit in the box.
Yes.
They don't because this all assumes that these disorders, these diagnoses are discrete.
Yes.
Pathologies. But if everybody's got 5 of them, that obviously they're not. The probability you have 5 independent neuropathologies is almost winning the lottery.
Yeah.
And so, but that's kind of what science, what we're doing assumes that.
Right.
So you only have to have depression, but not any other problems.
That's right.
I imagine if you probably are not seeing very many of those people, like you said, because you're seeing the hard cases.
Yeah.
But I bet that for people that just have a little depression and no other issues, maybe these antidepressants probably are fairly